Hello everyone and welcome back. So we are going to discuss the polycystic ovary disease. So we are having a scenario that there is a 20-year-old girl present with history of oligomenorrhea, hirsutism and complaints of infertility. So what is the diagnosis, the investigations and the treatment? So the characteristics of the polycystic ovaries are that is weight gain and hirsutism and irregular menstrual cycle, infertility and ischemic heart diseases. Now the causes are that it is due to the high level of androgen, the insulin resistance that is 70%, and obesity that is increased cholesterol, the high level of inflammation, and the genetic background. These are the basic causes of the polycystic ovaries. Now, the investigations that are done for PCOS are examination, that is GP, which on GP and pelvic examination, we will check for hirsutism, obesity, Cushing syndrome, and hump, moon face, parallelism, adnexa mass, and labial thickening. These are the physical signs that are present in the patient of polycystic ovaries. Routine investigations are CBC and blood group, urine RE, blood sugar, HIV screening, and hepatitis B and C. The specific investigations that are done for PCOS are LH and FSH levels, that is, LH will be increased while for FSH normal or suppressed. This is the hormonal assay of LH and FSH. Then baseline estrogen level increased, prolactin level is checked, which is increased, testosterone is slightly increased, and ultrasound is done, which is the investigation of choice, and diagnosis is made if three of the following features are present. That is peripheral distribution of the follicles, 10 or more follicles, that is 2 to 8 millimeter in diameter, and increased trauma and increased ovarian volume. So this was a hormonal assay. Now hysterosalpingography is done, hysteroscopy is done, diagnostic laparoscopy is done, and CT or MRI pelvis is done. The treatment options for PCO is that the treatment of choice is weight reduction. Metformin for insulin resistance is given, which is 500 milligram. Suppression of the androgen production is done. Ovarian suppression, that is combined oral contraceptive pill and gonadotrophic releasing analogs, and surgical treatment, which is ovarian wedge resection, laparoscopic ovarian, and bilateral oophorectomy. Adrenal suppression is done, that is dexamethasone plus androgens are given. 5-alpha reductase inhibitors are given, which is suppress the active form of testosterone, and finasteride is given, which is and finasterides are given, which are the treatment of hyperandrogenemia. Anti-androgens are given, which is along with the crepterone acetate and flutamide and spironolactone and ketoconazole. For menstrual irregularity and acne, OCPs and crepterone acetone is given. Hirsutism, for hirsutism, anti-androgens and laser hair removal treatment is done. And for infertility, clomiphene citrate and gonadotropin is given. The advice to the patient is that lose weight and the diet adjustment and the exercise. So we have discussed the topic of polycystic ovaries, and then we have discussed the scenario that there is a 20-year-old girl and she presents with oligomenorrhea, hirsutism, and complaints of subfertility. So the definition is that it is complex heterogeneous disorder with clinical and biochemical features, and the characteristics are acne, weight gain, hirsutism, irregular menstrual cycles, infertility, and ischemic heart diseases. The causes are high level of androgens, insulin resistance, obesity, high level of inflammation, and genetic background. Investigations, both the GPA and the pelvic examination is done, and then the routine investigations are done. Then the specific investigations are done, which are hormonal assay and ultrasound, and then hysterosalpingography, hysteroscopy, diagnostic laparoscopy, CT, and MRI. Then we have the treatment option. The treatment of choice is weight reduction. Metformin is given for insulin resistance, and the suppression of androgen production is given for ovarian suppression. Combined oral contraceptive pills and gonadotrophic hormone analogs are given, and surgical measures are done. Then this is the treatment for weight reduction, metformin, and androgen production. Then adrenal suppression is done by dexamethasone and androgens. 5-alpha reductase inhibitors are given, which suppress the active form of testosterone, and finasteride is given for the treatment of hyperandrogenemia. Anti-androgens are given along with crepterone acetate and flutamide, spironolactone, and ketoconazole. For menstrual irregularity, OCPs and crepterone acetone are given, and for hirsutism, anti-androgen and laser treatments are done. For infertility, clomiphene citrate and gonadotropins are used, and the advice to the patient is that lose weight and their diet should be adjusted and exercise should be done. Now coming towards the next topic, that is gestational trophoblastic diseases. We are having the H-mole. So the scenario is that a 28-year-old G3P2 presents with the 14-week pregnancy and bleeding PV with passage of the vesicles. Another scenario is that there is a G4P3 18 weeks case of hydatidiform mole, and the management, the follow-up, and the enumerate the risk of this condition and how we should prevent the patient from developing choriocarcinoma. So in gestational trophoblastic diseases, we have the H-mole, and these are the specific clinical feature with which the patient arrived at pregnancy is present there, and there is the history of bleeding, PV, and the passage of vesicles. This is the most common feature for the gestational trophoblastic disease. So, what is H-mole? It is abnormal pregnancy in which chorionic villi become enormously overdistended with the fluid and form grape-like vesicles, usually in absence of the intact fetus. We have complete mole and partial mole. So the risk factors for the H mole is blood group AB and B are on high risk, age under 15 years and 40 years, the previous history of the H mole, the previous miscarriage, the excessive smoking, and reduced carotene intake in female are the most common risk factors for the H mole. Okay, what is H mole? It is abnormal pregnancy, and the chorionic villi become enormously overdistended with fluid and form grape-like vesicles, usually in absence of the intact fetus. There is no fetus, and there is distended villi inside the uterus. Then we have complete mole and partial mole. The risk factors are these are the risk factors. Then what is the complete mole? It is abnormal pregnancy which consists of the placental tissues only, and there is no embryo in it. There are only placental tissues and there is no embryo in it. Then the genetic material is totally made in origin, resulting from the fertilization of empty anucleate oocyte lacking DNA material. Microscopically, it can be identified by three classic findings, which is edema of the villus stroma, avascular villi, and the nests of proliferating syncytial trophoblastic or cytotrophoblastic elements surrounding villi. Whole of the fetus is filled with vesicles and villus pattern is lost. There will be no fetus in case of complete mole. Most of complete moles have 46XX karyotype. All genetic material is paternal and few complete moles have 46SY pattern. This is the pattern of the chromosomes for the complete mole. So how we will identify? It is microscopically identified as that there will be edema of the villus stroma and there will be avascular villi and there will be the nests of proliferating syncytial trophoblast or cytotrophoblast elements surrounding villi. Now whole of the uterus is filled with vesicles and villus pattern. There will be no fetus in case of complete mole, and most of the complete moles have 46XS karyotype. All genetic material is paternal and a few complete moles of 46SY pattern. This is the diagrammatic presentation, and this is the homozycal diploid gametes. This is empty ovum, this is empty ovum, and it forms 46XS. This is 23XS and 23X, and this forms 46XS. This is empty ovum. Now, what is partial mole? In this form of H mole, embryo or fetus coexist with the placental abnormality, though it tends to die at an earlier gestation. These moles are triploid with 69 chromosomes and comprising of two sets of maternal and one set of maternal chromosomes. Okay, there are two paternal and one maternal chromosome. So focal molar changes occur in placenta, fetus and placental present, focal trophoblastic hyperplasia, and focal presence of the grape-like vesicles in the placenta, and more common than the complete H mole. And the following are the possible karyotype, that is XXY, XXX, and XYY. As there is one extra, one maternal chromosome and two paternal, so XXY, XXX, and XYY. This is the diagrammatic presentation. This is 23XX and X, so this is 69XXY. 23XX and X, 69XXS, 23X, 23X, 23, so 69XXY. Okay. Now, what are the clinical features? There will be the history of gestational amenorrhea, gestational amenorrhea followed by PV bleeding, history of the passage of vesicular tissues, nausea plus vomiting and hyperemesis gravidarum is present, early onset of the preeclampsia, abdominal pain and distension is present, uterine enlargement is present, fetal height is greater than POG, and thicker lutein cysts are present. Preeclampsia is present. Increased beta HCG level causing palpitations and sweating, and can be misconcepted with thyrotoxicosis. So these are the clinical features for the H mole. Now, how we will manage the H mole? First of all, the history of the patient is taken. That is the age of the patient, the previous history of the H mole, the race, the duration of the amenorrhea, the hyperemesis gravidarum. Then the examinations are done, which is the fetal height, fundal height greater than POG. As there is bleeding in the history, so its os is open. Now, the investigation options for gestational trophoblastic disease are routine investigations, serum beta HCG levels, which would raise double or triple that of normal pregnancy. Beta HCG has role in diagnosis, treatment, and follow-up. Ultrasound is done which has high echogenic area or tissue present appearance on the ultrasound. In ultrasound, the complete mole and the partial mole appearance. Incomplete mole, snowstorm appearance of the vesicular tissue is present. There is no fetus, no amniotic fluid, and huge lutein cyst is present. In partial mole, focal snowstorm appearance is present, fetus is present, and amniotic fluid is present. The X-ray chest region, which is common bile appearance of lungs, this is done due to exclude metastasis. And CT scan brain is done, MRI is done, and exclude thyrotoxicosis is done. So the treatment options are: treatment is to terminate the pregnancy. If patient comes with bleeding PV, first arrange blood after doing all the investigations. Then suction evacuation procedure is done. That is, suction cannula is used in this case. Dilate the cervix with Hager dilator. Introduce suction cannula in uterine cavity and aspirate vesicles, and size of the uterus will reduce. Do not cure it, as uterus is soft and can be perforated. Now, bleeding is an important complication of this procedure, so intravenous line has to maintain through which intravenous fluids and blood could be given, plus ergometrin is given. Never give oxytocin in drip while during evacuation because it leads to emboli. Now, the follow-up for for this treatment is that comprehensive follow-up after evacuation is required because the 3% risk developing choriocarcinoma and 20% risk of recurrence. Regular beta HCG levels fortnightly is done. It is best due to weekly till it becomes negative, then monthly for 1 year, and then 3 monthly for next year. Total 2 years follow-up. Ask the patient to report if there is any bleeding with vesicles and advise contraception barrier method. Don't use hormonal contraceptions in the follow-up period. After this, in every pregnancy, do serum beta HCG 3 weekly because even normal pregnancy chances of choriocarcinoma is there. Pregnancy after 2 years follow-up, early ultrasound to exclude H-mole in next pregnancy is done. Differential diagnoses are H-mole, threatened abortion, multiple pregnancy, ectopic pregnancy, fibroid uterus with pregnancy, and the complications of H-mole are choriocarcinoma, preeclampsia, thyroid problems, recurrence, and hemorrhage and sepsis. So we have discussed the gestational trophoblastic diseases. First, we have discussed that there is a 28-year-old G3P2 present with 14 weeks pregnancy and bleeding PV with passage of the vesicles. We have discussed the scenario. Then we have discussed the definition for H-mole, which is abnormal pregnancy in which chorionic villi become enormously over-distended with fluid and form grape-like vesicles, usually in the absence of intact fetus. Then we have discussed the risk factors, which are blood group A, B, and B. What are on high risk: age under 15 and 40 years, previous history of H-mole, previous miscarriage, excessive smoking, and reduced keratin intake. These are the things which are, if present in a woman, then the woman is at high risk of the mole pregnancy. Then we have complete mole, and we have discussed that what is complete mole, then the partial mole, and then we have discussed the clinical features, that what are the clinical features of the gestational trophoblastic diseases. Then we have discussed the management options, which are history taking and examination and investigation. And investigations, we will do the routine investigations: serum beta HCG levels, beta HCG ultrasound, and X-ray chest, CT scan barrier, MRI, and exclude thyrotoxicosis. And the treatment options are done, which are the treatment to terminate the pregnancy, and suction and evacuation procedure is done. Then we have discussed the follow-up for the treatment, and then we have discussed the differential diagnosis and the complications of H-mole. Now, in the next section, we will discuss the benign diseases of the uterus, which is fibroids, and the fibroid uterus, the differential diagnosis, and the investigations for it. Thanks for watching.